Thank you, Angie. That was a really interesting presentation. We're now opening the session to the audience. I think we've got about 15 minutes or so for that. And I can see we've already got a number of questions coming through. So I'm going to try and take them in order that they've been sent. So we have Peter 4 asks, I think I've got this in the right order, what assessment can be undertaken to choose the right size of the catheter before insertion to avoid bladder injury?
Hi there, thank you for those questions coming through. So there are several different assessments that can be done to choose the right size catheter. The first thing to always think about is to make sure it's the right length. A standard length catheter should always be inserted in men. And for women, often we use a standard length catheter, but there are shorter female length available. So we first need to make sure that we're always using a standard length catheter in men. When we then come to sizing of the catheter, it's dependent on several different things. As a general rule of thumb, most catheters that we insert would be a size 12 or 14 Chariot. And they're the standard ones which most hospitals are standardized to. However, in certain cases, if you're using a catheter for irrigation, you need a bigger catheter, or if someone's got a lot of debris and their catheter keeps blocking, then we sometimes need to increase the size. If we're thinking about avoiding bladder injury, it's not necessarily the size. Having a larger catheter doesn't cause a bladder injury, it's just more uncomfortable. And so what we would generally say is go for a 12 or 14 as a standard, unless there's an indication to increase the size, and always use a standard length in a man.
Lovely. That kind of links on to a question from Alison here, who says, can you explain how you know if a catheter is a female or a male catheter, as it does not usually specify on the catheter packaging?
So it will never say male length catheter, it will say standard catheter. Okay, so all catheters are standardized to one size. I'm going to turn my camera off because it keeps playing up. Only the female lengths will specifically say female length catheter. All the others will say standard size catheter.
Lovely. Thank you, Angie. Maya asks, hi, Angie, with regards to the comorbidity slide, are there any of these a greater risk to females over males or vice versa?
So when it comes to comorbidities, there are certain ones that are more prevalent in women. So we know for certain neurological diseases such as multiple sclerosis, more women are likely to have that. There are certain ones that are more likely to be seen in men, such as sort of spinal cord injury. However, overall, for the diabetes, the pulmonary disease, things like that, I'm not aware of a significant difference between the sexes in prevalence of those issues.
Okay, thanks for that. Jessica Nunn asks, I'm a student mental health nurse and never knew psychotropic medication can impact bladder function. Should this be something I'm inquiring about with service users who are prescribed such medications?
Very much so. Psychotropic medication can affect the bladder in several different ways. There are a group of drugs that cause urinary retention. So when we look at certain drugs, things like duloxetine, used for depression and neuropathic pain, increases the contractility of the urethra and helps and reduces leakage. It's actually a drug for the treatment of stress incontinence. So that can cause urinary retention. There are other ones such as lithium that cause a constant sensation to want to pee and cause urgency and frequency. Many of the other drugs, your olanzapines, all have an impact on the bladder and change sensations and symptoms. So it's really important for any patients, particularly on psychotropic medications, to look at if they've had a change in bladder symptoms when they've started new medications.
Great, thank you for that. From Peter, again, for patients who undergo surgery like a Wertheim's hysterectomy, it's recommended that the catheter in situ remains for 10 to 14 days. Why is that? Can that impact the bladder, and what can be done to prevent UTI?
Okay, so a wartime hysterectomy is quite a radical hysterectomy that's generally done for cancer, where they're removing pretty much all your pelvic structures. The bladder is very, very close to the uterus. Sometimes it can be a bit stuck onto the uterus, particularly if that person's had any previous cesarean sections or pelvic surgery. And in any pelvic surgery, there is always a risk that the bladder can become injured or damaged as part of the procedure. The bladder would always then be repaired and monitored at that point, but it needs to have a rest period for a certain period of time to allow it to heal and recover before you start making it function. So if there has been some form of bladder injury, it could happen at a bladder injury during a cesarean section or any other pelvic surgery. The catheter allows complete bladder rest while it heals, and then you would start a trial without catheter. There are some evidence to say that people that have had lots of pelvic surgery can impact bladder function in the long term. And so it can impact the bladder, but it's very much dependent on lots of other reasons and the rationales behind the surgeries.
Okay, that kind of links on to another question from Maya about how long post C-section surgery should a catheter ideally be removed and a trial without catheter start?
So this depends on what sort of program and what sort of anesthesia the person's had. If you look at the NICE guidelines for intrapartum care, we know that it can take 8 hours of after discontinuation of the epidural, the sensations to start to return to the bladder. So NICE guidelines tell us that women should have their catheter for 12 hours or have their catheters removed 12 hours after stopping the epidural anaesthetic. Now, there are some enhanced reduced length of stay programs that are going on in maternity to look at improving the turnaround and discharging patients home sooner. And they're having slightly different epidural anaesthesias that's allowing them to mobilise much quicker. So some catheters are being removed earlier if it's part of an EROS program, but generally NICE guidelines says at least 12 hours after the discontinuation of the epidural.
Great. And Rachel says, we only have male catheters in our hospital. This means our female patients are catheterized with male catheters. Are there any contraindications in terms of increased risk of CALT?
Okay, so this was something that many trusts over the years have standardized so that all patients have a standard length catheter. This is because there were cases when a female length catheter was put into a man, and that can cause significant trauma and damage to the urethra. And this is actually one of the NHS England never events that's safety networked and safety pathways. So in order to prevent that happening, a lot of hospitals over the UK changed to only have standard length catheters available, except in certain specialist areas. Now, in reality, for most women, as long as that catheter has an appropriate catheter fixation device on it and the bags are appropriately secured, as you would expect, it doesn't have any increase in terms of UTI rates associated with it. The only time it can be a problem is if you have a woman that is incredibly short. And then often with the longer length catheter, when the bag's attached, it's dangling around their ankle, and then that increases the infection risk. And in those cases, the specialist areas can get the shorter length catheters. But it's down to the fixation device, the daily meatal cleaning, and the bag securement more than the length that causes the CALTs.
Right. Ranjit says, do you have anything available which is given to the patient with date of insertion, size, etc.? They have a catheter passport which is given to each patient with a catheter on discharge. Sounds like a great idea.
Yeah, so a catheter passport, again, is an idea that was, so back in about 2018 with NHS England, we launched a excellence in continence care. And that was one of the things that was flagged up as best practice. And so the recommendations are nationally that all places that are discharging patients with catheters all patients should receive a catheter passport. And that's something that not only puts all the details about insertion in, it has basic education for the patient on catheter care, it has sources of how they then seek help, it has space for them to put questions, but then it also has a space for any other healthcare professional that may meet that patient in the community, change their catheter, to add comments in. And so it's something that is actually nationally recommended as best practice.
Right. And Lenny says, how long should a short-term catheter stay in situ?
So it depends on the brand of catheter. Different brands of catheters have different shelf life. Some short-term catheters are only good for 7 days. Some are licensed for 28 days. The long-term catheters are generally licensed for 90 days. But each individual brand will have the length of time that catheter is licensed for. And it's about reading the information leaflet that's printed on the label or within the box that you're getting it from to know from there. A lot of the more specialist catheters, such as the ones that are the silver coated catheters and things like that, again, are only licensed for 28 days.
And conversely, Fiona Goodridge says, how often should you change a long-term catheter?
So if they're not having issues, and if they're not having issues with blocking, encrustation, any or recurrent infections, then 90 days is the license length of use for the catheter. So about every 12 weeks.
Right. Monique Tompkins says, why aren't catheter valves used more frequently? They're brilliant.
So catheter valves are good for certain patients. Okay, they're not good if patients don't have the good dexterity to be able to use them. But also, if you have a patient that you want to have complete bladder rest, they don't allow the bladder to rest, because with the use of the valve, the bladder still has to fill up and then it's emptied via the catheter. So in patients you want complete bladder rest, they're not good. And we also have to be careful, because if the patients aren't able to empty the valve themselves, then sometimes there's not always the staff available at the time and problems can happen. But in certain groups of patients, yes, they are very, very good. And if we're using it to retrain bladders prior to undertaking trial without catheters, they are also great, but they're not for everybody.
We've got some great questions coming in. I'm not sure we're going to have time to get around to all of them, but I'll try and get through as many as I can. Kristen Miller asks, in acute urinary obstruction, would you try indwelling or in and out catheterisation? And what's the management for this? So
it would depend on the patient and the rationale behind the obstruction. You know, if they have got a stricture, then sometimes having an in and out catheter might cause issues. If they've got if they're severely constipated, you need to manage the issue first beforehand. So it depends on the patient, the situation, and what they want to do. For many people, you can offer them the opportunity, if you have the expertise, to teach them to self-catheterize at that point. But often in acute cases, we'd try an indwelling first and then look to teach them self-catheterization, safety netting once you've managed the acute problem.
Okay, that's that. And Robert Richards says, in long-term catheterization, is urethral or suprapubic catheter best?
So if someone is going to be long-term catheterized, suprapubic is generally always the best option, for several different reasons. Number one, it's associated with a lower rate of catheter-associated UTIs, because by coming through the tummy, you don't have the contamination from all the perineal bacteria that you have. So there's reduced urinary tract infections. In women, it's far more comfortable to come through the tummy, because if you're sitting on it all the time with a long-term catheter, it can cause blistering of the vulva. And we also know that if people have catheters long-term urethral, so sort of I'm talking a couple of years here, it can actually cause erosion of the bladder neck and trauma in the urethra, which can cause significant problems. The other thing is, for people that are having it long term, from a sexual function point of view, having the genitals free to be able to continue a sexual relationship as they may like is far preferable. So having a suprapubic catheter is far better from a sexual function point of view.
Yeah, makes sense. Susan Fraser, leading on from that, says, why do long-term catheters tend to build up debris and have higher risk of blocking? Have seen this with urinary catheters and suprapubic in the community.
So with any catheter that you have, there is a risk of building up of debris. Whenever you have a catheter in for a prolonged period of time, you get what they call biofilms that create in the lumen of the catheter. It can be very much associated to whether their urine is acidic or alkaline. It can be associated in people that have particular thrush, diabetes, they get more candida, and that can cause blocking. Often it's associated with other medical conditions and medicines. For people that do have the longer term catheters that tend to get this build-up and debris, that's where patients would be having regular bladder washouts with some sort of bladder washout solution that would happen once or twice a week to help maintain the lumen of the catheter to prevent it. Or we'd be looking at their diet, we'd be looking at what they're drinking, we'd be looking at other medications to try to manage that. We'd also look at, there are catheters that are open-ended. So instead of just having small little drainage holes that often get blocked with debris, you get open-ended catheters that don't have a tip. And so you get better drainage. So we look at changing catheter type to manage those problems.
Brilliant, thank you. Christine looks like she's been quite persistent with her question, so I shall ask this. She says, is it recommended for patients with long-term catheters to take oxybutynin long-term, and why?
So it's not a recommendation. For some patients that have a long-term catheter, there can be many different rationales behind it. Oxybutynin is an anticholinergic drug that reduces bladder spasms. So for some people, if they have an underlying overactive bladder, the bladder then spasms, and that may cause them to bypass their catheter and leak around the catheter. So by having a medication that calms the bladder down and prevents the spasm, that can reduce bypassing of the bladder. So that is an issue for people that either have an underlying overactive bladder that then have a catheter in. If people are just bypassing the catheter and didn't have that problem beforehand, before I started oxybutynin, I'd want to be looking at managing constipation. I'd want to make sure that the catheter is secured appropriately, that it's draining appropriately, that they're not drinking lots of caffeine and fizzy drinks that's going to irritate their bladder and cause that they don't have a urine infection. So for many people, I would be wanting to look at other things before putting them on oxybutynin. And again, oxybutynin shouldn't be used in anybody over the age of 65. And we often find that people with long-term catheters tend to be in the older age group. So again, it's a case of looking and modifying drug therapy in line with the patient.
Lovely. I think we've got time for just quickly one more question, if we can. Claire says she's in the community and we use bladder washes. I've heard that we're trying to move away from bladder washes. Is this true?
There are different rules, there are different ideas everywhere. There are some places that people used to use bladder washes rather than trying to change a catheter if there were concerns that the bladder was not emptying and that the catheter was blocked. And so we're trying to move away from that. We should just change the catheter rather than trying to flush it. But actually for certain patients, certain bladder washouts are good. I think the problem more is it's manpower and hours. Actually, you know, having to have a district nurse or a community nurse go to someone twice a week to perform a 20-minute procedure when the staff in the community are struggling so much already, it's more about manpower. We teach a lot of patients to do their own bladder washouts if they're able to or family do. But clinically, it's not a national thing to say this about. I think it's just looking at manpower issues.
Lovely. Thanks, Angie. I'm so sorry, everyone. We look like we've run out of time, but what a great session, Angie. Thank you. And thank you to our audience. I do hope you've found this webinar valuable. Please remember to register for the Clinical Skills Forum 2023 on the 6th and 7th of June. This will be a highly interactive 2 days online of working groups, panels and case scenarios to help you and your organisation support nurses learn all the necessary core skills and ensure that you have continuous clinical skills development in practice. The next webinar, which focuses on infection prevention and control, will be on Wednesday, the 27th of September. Thank you again, everyone, and I'm so sorry we didn't get around to all of your questions, and see you again soon.